Hi everyone, it's Dr. Custer here. Today we're going to do a lecture on incidence, prevalence, and risk. I call this the basics. So the usual disclaimers. You guys all know I'm not a statistician. I just understand a little bit of stats and I'm just explaining it to you. This video is for educational use only and is not intended to be sold. Please contact me at the email listed if you'd like to collaborate on a project. And I don't have any real disclosures other than I may have taken parts of problems off stuff I found on the internet. So let's get started. The goals of today's lecture, we're going to review prevalence, incidence, and risk, very briefly attributable risk, and then we'll go over relative risk, odds ratio, and correlation because I forgot to put it in the other video. So, this is a lot of information, you guys. If you're the kind of person that likes to take notes, I advise you to go grab your notebook because we're going to cover a lot. All right, so let's get started. What is epidemiology? Epidemiology is the study of how often diseases occur in different groups of people and why. And why is it important? Why is epidemiological information important? It's used to plan and evaluate strategies to prevent illnesses and also a management guide for people who already have disease that's developed. So it's really important that we understand what we're dealing with today. Prevalence and incidence are ways to measure morbidity frequency, i.e. the number of persons in a population who become ill, which is known as incidence, or are ill at a given time, which is known as prevalence. We'll start with prevalence. So prevalence is a measure of the total number of cases, and that includes new and old cases, measured at a particular point of time, and this is known as point prevalence. And it gives you a snapshot of a disease process. You can also measure period prevalence, which can be over a period of time, but we're not going to go over that in any detail. So here's the formula for point prevalence, and you'll see that it's just the total number of cases at the time over the total population, of course, times 100. All right, so that's prevalence. How many cases at a specific point in time? So prevalence is a function of both incidence and duration of disease. So let's go over that. What does that mean? So think about diseases with a high mortality rate, for example, an aggressive cancer, or stuff with a quick convalescence like the flu. Even if your incidence is high in those cases, you still have a low prevalence. Now let's think about like chronic diseases where patients tend to live for a longer amount of time with these chronic diseases. Even if the incidences are low, you will have a high prevalence because as people age, they continue to have these chronic diseases. A note on prevalence, it also can be used to assess the frequency of behaviors or characteristics that could be risk factors for the disease. For example, smoking. Tobacco use isn't a disease, it's a risk factor, but it is relevant to assess it as the prevalence of the behavior. And so the prevalence for a behavior or characteristic looks just like the point prevalence formula, where it'll be the total number of people having the particular behavior over the total population at time, of course, times 100. So that's prevalence. We'll move on to incidence now. So incidence would be the number of new cases of a disease over a specified time period. So whenever you hear new cases, you should think incidence. One thing to note, the accuracy of your incidence data depends on the accuracy of diagnosis and reporting of the disease. So all that means is if you have a technique come out that increases accuracy of diagnosis, your incidence will go up because you'll be IDing more. And we'll go over that. So 2 things for incidence. There's cumulative incidence, which is what you guys will typically be doing problems about, and then there's incidence rate. And I want to go over each. So cumulative incidence is like, tell us the incidence of a new disease during this time period. So your incidence is the number of new cases in the specified time period over the number of people at risk, times 100. So let's go over this in more detail. A couple things to note. For incidence, pre-existing cases cannot be included in the numerator because they're not considered new, right? So they'll give you a time period. If people come into the study with pre-existing diagnosis or a diagnosis at the time of the beginning of the study, those are not included in the numerator. And they're also excluded from the denominator, which makes sense, right? So for incidence, we want to know the number of people at risk for the disease. If you have a pre-existing case, then that is no longer at risk. And then cumulative incidence presumes that the at-risk population are observed for equal amounts of time. Like everyone's observed for 1 year, for example. Incidence rate tells us the risk of disease when there's a variation in the lengths of time that at-risk individuals are observed. So this would be expressed as the number of new cases, just like cumulative incidence, over the total person time. And then the 3 points are the same, other than the third, which presumes the at-risk are observed for variable amounts of time. But still, pre-existing cases are not included in the numerator because they're not considered new cases and also are excluded from the denominator. I don't think that they'll have you do an incident rate full calculation, but they might mention a number of new cases and they might say like person years or person days, and then you would know to calculate the incident rate. All right, so let's go over some effects on incidence and prevalence. These are classic board topics. So let's start with a chronic disease treatment. So something that prolongs patient survival would increase prevalence. Makes sense, accumulation over time. However, the incidence would be unaffected. If you note that you have increasing prevalence despite a stable incidence, you know that that's usually related to an improved quality of care. So lots of changes in medicine. So this could be a very real possibility as care increases and the resultant decrease in mortality occurs. You will see an incidence that is increasing. Prevalence that's increasing. Cases where you have an improved diagnostic accuracy for a chronic disease increases the incidence. More cases are identified, obviously, and the prevalence. And this is what we were talking about on the slide a couple slides ago. You're just able to detect it more, so your incidence will elevate. And then the last thing is primary prevention, otherwise known as vaccination, decreases incidence of a disease and eventually decreases the prevalence, and this makes sense. So this is Connor's bathtub. I found the bathtub on Google relating incidence and prevalence, and my son said, "Oh, I'll fix that for you." So this is his art. So the bathtub. So you can see the incidence here. And remember, incidence is new cases, so these are the new cases flowing into the bathtub. Think of the bathtub as the population of interest. And here, the water that's in the bathtub is your prevalence. Things to consider. There will be a reoccurrence rate that you have to consider going into this. And then you also will have some people that are cured in recovery or death, which is mortality rate. And that's, imagine a drain here. Oh, I'm going to have a mouse. A drain here that's leaking water out, and those are the recovery and cures, and the deaths. So that's one way to remember incidence and prevalence. All right, so this is looks like a complicated slide, but it's just a slide created by this image was created by the CDC, looking at 10 new cases of illnesses over about 15 months in a population of 20 persons. So from this, let's see what we can figure out. So first, let's talk about point prevalence. Now remember, point prevalence is a specific time. So we're going to say, what was the point prevalence on April 1st, 2005? Now, when you take a look at these charts, you'll see the arrow down is the date of onset of illness. Pluses are the date of death, and arrow ups are date of recovery. When we go to April 1st, remember, total cases over total population is the definition of point prevalence. Here we have 1, 2, 3, 4, 5, 6, 7 cases at that date. And then what's our total population? Well, we know it's 20, but here, look, 2 people have passed. So our total is 18. So our point prevalence would be 7 out of 18, which is 39%. The other thing they might ask off of this is, what's the cumulative incidence from October 2004 to September 2005? So let's look in this time period. The first thing they want to know is the top part, which is how many new cases. So remember, we don't count the ones before, we count the ones that occurred during the time period. So here's 1, 2, 3, 4. So there's 4 new cases. And then remember, for a denominator, we have the total population at risk. So we started this study with 20 persons, but here we see we have 6 that already had the disease before the study period began. So we're going to exclude those because remember, they're no longer at risk. So the cumulative incidence would be 4 new cases over 14 total, and that would be 29%. So those are just examples of what they might ask you for. We're going to do a couple quick questions and then move on to risk. So a new combined chemotherapy and immunotherapy regimen has been shown to significantly prolong survival in patients with metastatic melanoma. If widely implemented, what would you expect to see? So we talked about this. So a new regimen to treat a disease and prolong survival wouldn't affect incidence at all. It wouldn't affect the new cases. However, remember, over time, people are surviving, so it would increase your prevalence. So out of these choices, really your incidence does not change, but your prevalence increases. So the answer would be D. All right, let's look at this. These problems are so wordy, I know. A sample of 200 middle-aged and elderly women was followed prospectively for 10 years, ending in January 1999. None were lost to follow-up. During this period, 6 subjects were diagnosed with breast cancer. All survived to the end of the study. And then the problem gives you the times at which these 6 subjects developed cancer. And the question is, well, that's supposed to be breast. What was the prevalence of breast cancer at the end of the study? So here we're talking about point prevalence, remember. At the end of the study, we still have our 200 sample. Remember, none were lost to follow-up. And we assume none perished. And then they want to know, so their total population is 200, and then how many cases at the time? There were 6. So here we see 6 over 200, or 3%. So that would be the prevalence at that point. Oh, my bad. All right, this one's a lot of words. In a survey of 1,000 IV drug abusers in Town A, 200 turned out to be infected with hepatitis C and 50 with Hep B. During 1 year of follow-up, 200 patients with Hep C infection and 100 patients with Hep B die. Also during follow-up, 100 patients acquire Hep C and 50 acquire Hep B. Which of the following is the best estimate of the annual incidence of Hep C in IV drug abusers in Town A? All right, so there's a lot of numbers and hepatitis is in this problem. So I say just pull out the important information first. We see that our total population is 1,000 in Town A, and at the beginning of the study here, we see 200 turn out to already be infected with Hep C. And then it says 100 acquire Hep C in that period. So 2 things to note. So our annual incidence states right here there were 100 that acquire, so there's 100 new cases. But then we have to think about our denominator. We know there's 1,000 patients total, but if 200 already have Hep C, then they're no longer at risk and excluded from the denominator. So the answer would be 100 over, there's our little handy formula in case you forgot. And there's the right answer. All right, let's move on to risk, you guys. Risk is the probability of an event occurring over a certain period of time. They have three things that I need to make sure you know. Attributable risk, relative risk, odds ratios. So attributable risk is just how much of the risk was attributed to the exposure. It's a difference in the disease rates in exposed and unexposed individuals. Another way to think about it is a difference in the probability of disease in an exposed person and the probability of disease in an unexposed person. This does imply a prospective design. And then back to our handy 2x2. We're just looking at risk of disease in exposed minus the risk of disease in the unexposed. And that would be your attributable risk. It's pretty simple and pretty easy once you know relative risk to go back and just remember to subtract. Now relative risk, we're going to go through this for a couple slides. Relative risk compares the probability of developing an outcome or disease between two groups over a certain period of time. It compares those who had an exposure and developed that disease or outcome to those who didn't have the exposure and developed the outcome. And again, this implies prospective design, so we're talking about cohort studies. And here we are back to our handy 2x2. So here we go. Relative risk, the probability of developing this outcome if you had the exposure versus if you had no exposure. And that shows you your relative risk of disease. So you're looking at people that were exposed, had the outcome, over everyone who was exposed, divided by people who had no exposure, still had the disease, over everyone who didn't have the exposure. So another way to think about relative risk is, within certain period of time, how many times are exposed people more likely to develop a particular event compared to an unexposed people? And this is just the way I like to think about it. It's basically saying, you know, for the total patients that had the exposure and developed the disease over everyone exposed, over the patients that developed disease without the exposure over the total that were not exposed. In relative risk, just like odds ratio, the scale goes from 0 to infinity. A value of 1 indicates no difference between groups, so there's no risk. And if the disease is very rare, your odds ratio will approximate your relative risk. And remember, you guys, if it's less than 1, it's a reduced risk, and if it's over 1, it's an increased risk. So, this is a very complicated example. An observational study in diabetics assesses the role of an increased plasma fibrinogen level on the risk of cardiac events. 130 patients are followed for 5 years to assess the development of ACS. In a group of 60 with normal baseline PFL, 20 develop ACS and 40 do not. And in a group of 70 patients with a high baseline, 40 develop ACS and 30 do not. So what's the best estimate of relative risk in patients with a high baseline PFL compared to patients with normal? Holy cow, if I was sitting for step 3 and I was reading this question, I would be sad. But alas, they do give us all the information we need in the middle paragraph. So, in a group of 60 patients with a normal baseline PFL, and you guys can, obviously you guys see what's going on here in this table. Out of those 60, 20 develop ACS and 40 do not. Then, in a group of 70 patients with a high baseline PFL, 40 develop ACS and 30 do not. So it's just a matter of plugging and chugging into these charts. And then I just do the math from there. So what's the best estimate of relative risk? And here's the choices they give us. Now I will put up your formulas to remind you of this. So remember, risk of disease in the exposed over the risk of disease in unexposed. So we're talking about 40 over 70 over 20 over 60. And there we go, that's our answer. All right, odds ratio. So relative risk is looking at prospective design. Odds ratio is looking back in a retrospective way, so case control studies. So odds ratio compares the odds of an exposure to a particular risk factor in cases and controls. So it's the ratio of the odds of exposure among cases to the odds of exposure among controls. And so the odds of exposure to the cases and the odds of controls. So we're looking at, here's our cases. So the odds is just A over C, exposure over no exposure. And then controls, remember, just exposure, no exposure. And then we say, okay. Now, because it's been a long time for some people to do basic math, yes, I did write this out. But just another way to remember, whatever works for you, whether it be thinking about the table, doing this math, or just this bottom part here, use one of these ways to, calculate the odds ratio. All right, another way to look at it is how many times are diseased people, aka cases, more likely to be exposed to a particular factor compared to non-diseased people, aka controls. So you see here, these are the cases, these are the controls, and then it's just the odds of exposure to non-exposure in each case. So that's just another way to think about odds ratio, just like the relative risk. And just like relative risk, this is a scale of 0 to infinity. 1 indicates no risk, and the odds ratio will approximate the relative risk if the disease is rare. So here's an example of an odds ratio problem. At a specific clinic, patients diagnosed with and without breast cancer are asked about their current alcohol use. The following table is constructed. So from this table we see we have 100 cases and 200 controls. And then we have it broken down from greater or equal than 3 drinks a day or less than 3 drinks a day. And you guys can see the numbers. What is the odds ratio that a patient diagnosed with breast cancer consumes 3 or more alcoholic drinks per day compared to a patient without cancer? And then here's your options. And so we're going to look, and remember odds ratio is the cases over the controls. We have 70 over 30 over 60 over 140. And so in this case, the alcohol, there's our formula. Alcohol, the odds ratio would be 5.44 in this case. All right, let's blow through correlation real quick. I'm sure you guys are ready to be finished. It's just a way to test relationships or associations between quantitative or categorical variables. So in other words, a measure of how things are related. And you all know it's shown on scatter plots. So here we have from a perfect positive to a perfect negative correlation shown. And just remember the correlation coefficient, the R, ranges from -1 to 1, and it does measure both strength and direction. So a positive 1 would be a perfect positive correlation, and a -1 is a perfect negative correlation, and 0 is none, and then everything in between. So let's take a little bit closer look here at our correlation. So just some examples of positive correlation, which just basically means as one variable increases, the other also increases. And then you would see, the slope like this. And things like that could be, for example, weight and calorie consumption. So as one goes up, the other, blood pressure and dietary salt consumption, etc. Now we look at the negative correlations, and we see as one variable increases, the other decreases. So that's negative. And 2 examples I thought of were increased compliance rate with care and mental health symptoms, and then increased vaccination rate and incidence of flu in a population. So obviously, as the vaccination rate increases, the incidence of flu decreases. And then no correlation would just be no associating of variables. And for example, car color and fuel efficiency have nothing to do, of course, my mouse. Here we have no correlation. You guys see it's just, it's all random. And then diet and eye color would be another example. All right, one more thing before we end, and that's the correlation coefficient of determination. So the coefficient of determination can be calculated by squaring the correlation coefficient, which is R we just talked about, And this number expresses the percentage of variability in the outcome factor that is explained by the predictor factor. And so for here, for example, R squared, which is what the coefficient of determination is, my crazy mouse again. So here we have folic acid intake, and then we have plasma homocysteine level. And we see our R is negative 0.784, and it's significant. So our R squared would be obviously just that number squared, which would be 0.614 or 61.4%. And basically what we can say is 61.4% of the variability of the homocysteine levels is due to the folic acid intake. So that's that. So in summary, prevalence, we got total cases over the total population. Incidence, we're thinking new cases over the population at risk. Relative risk is the risk of disease with exposure compared to no exposure. Odds ratio, the odds of exposure with disease compared to those without disease. And then correlation, which is the measure of association. So I hope you guys got a good review of all of these. If you have any questions, please contact me. My email and text are below, and I do prefer text or email. After this, you can go back to New Innovations to obtain the link to the post-lesson quiz.